the antiplatelet therapy in the acute setting of ischemic heart disease. Acute coronary syndrome is considered a major sector in ischemic heart disease patients. These acute coronary syndrome patients may compare patients with unpresented with unstable angina, patients with non-ST segment elevation myocardial infarction or non-STEMI, patients with STEMI, patients with ST segment elevation myocardial infarction. In these subsets of patients, antiplatelet therapy is considered a cornerstone in the management of these patients, whether these patients managed medical, conservative treatment, or managed intervention during PCI. Our case is a female, 62 years old, known to be diabetic since 5 years, hypertensive since 7 years, with definite history of ischemic heart disease. The patient is performing drug standard to LAD after positive stress test for stable heart disease. And the patient presented to the ER with recorded chest pain, 2 hours since 2 hours. So these patients, these female patients presented with well-known history of ischemic heart disease, presented with chest pain. If this patient is considered a acute coronary syndrome case or not. What are the guidelines recommend regarding the management of these patients for diagnosis, risk stratification, and imaging? These patients known to be ischemic, presented with chest pain. Guidelines recommend to obtain or to measure high-sensitive troponin within 60 minutes from the first medical contact, and the guidelines also recommend to obtain a 12V ECG within 10 minutes from the first medical contact and this ECG to be interpreted by experienced physician. This is the ECG of the patient. And it is clear that the patients have significant and diffuse ST wave changes, anterior, lateral, even inferior. If this patient is considered an acute coronary syndrome case, the patient have little bit elevated blood pressure with an average heart rate, little bit obese, have an audible apical S4, which may indicate that this is maybe acute event with positive troponin, elevated troponin level. So, patient known to be ischemic, diabetic, hypertensive, have history of drug stent or have history of BCI, presented with typical chest pain, have significant ECG changes with elevated troponin. Definitely, this patient is considered a case of non-STEMI acute coronary syndrome. The patient is loaded with 600 milligram clopidogrel, 100 milligram aspirin, enoxaparin, 20 milligram rosuvastatin, and patient is considered for candidate for PCI. What about the antiplatelet therapy recommendation for this patient? The patient should be kept on the same treatment, receiving clopidogrel, or substituted with Ticagrelor 90 milligram BID next day, immediate shifting to Ticagrelor 180 milligram or adrivaroxaban 2.5 BID. According to the guidelines recommend that any patient considered acute coronary syndrome should be switched or loaded immediately with Ticagrelor 180 milligram and kept on this drug 90 milligram BID as maintenance dose. What are the available antiplatelet therapies that we have? We have clopidogrel. In such patients, the clopidogrel should be loaded with 600 milligram, and then the patient is maintained to 75. Prasugrel, 60 milligram loading dose, and maintained on 10 milligram. This is a standard dose, or maybe reduced to 5 milligram. That's once daily in patients aged more than 75 years, or if they weight less than 60 kg. Ticagrelor, loading 100 milligram, then maintenance 90 milligram BID, or Cangrelor. So this is the only antiplatelet drug available IV. The drugs differs in their onset of action. Clopidogrel may have delayed onset of action, about 2 hours to 6 hours. Prasugrel, rapid, half an hour to 4 hours. Ticagrelor, rapid, half an hour to 2 hours. Cangrelor, immediate, since the drug is taken IV. So, So that's why ده أحد الأسباب اللي بتخلي Ticagrelor recommended by the guidelines in patients with acute coronary syndrome because of its very rapid onset of action. The drugs also vary in their offset of effect. Clopidogrel takes about 3 to 10 days to fade. For Prasugrel, 5 to 10 days. Ticagrelor, 3 to 4 days. Cangrelor, 30-60 minutes. So this is also أحد الأسباب اللي بتخلي guidelines recommended Ticagrelor because it's a rapid offset of effect. And so once the patient is need for any surgical intervention, it is easy to stop the drug about 3 days, then to proceed. What are the guidelines in 2020 sees regarding these patients presented with non-SC segment elevation acute coronary syndrome? Aspirin is recommended for all patients without contraindications at initial loading dose as 150 to 300 and maintained on 75% for long-term treatment. P2Y12 receptor inhibitor is recommended in addition to aspirin and maintaining it for 12 months unless there are contraindications or an excessive risk of bleeding. What are the options of these antiplatelet P2Y12 receptor inhibitors? First option, Prasugrel. Prasugrel is indicated in patients proceeding to PCI at loading dose 60 mg, then maintenance dose 10 or 5 according to the Asian rate. Ticagrelor is recommended irrespective of the planned treatment strategy. Any patient presented with acute coronary syndrome should be loaded immediately with Ticagrelor, whether this patient is going to be treated in this medical or invasive, is going to do PCI. Clopidogrel, only when Prasugrel or Ticagrelor are not available or can't be tolerated or contraindicated. Prasugrel is recommended, should be considered in preference to Ticagrelor in non-ischemic acute coronary syndrome patients who proceed to PCI. What about the guidelines say regarding diabetic patients or pre-diabetic patients presented with acute coronary syndrome? Ticagrelor or Prasugrel is recommended in patients with diabetes presented with acute coronary syndrome for at least 1 year plus aspirin if these patients is going to be treated medical or will proceed to BCI or CABG. So according to the guidelines, in patients with non-ischemic acute coronary syndrome, these patients, even if they are previously exposed to clopidogrel, the guidelines recommend the switching from clopidogrel to Ticagrelor early after hospital admission at loading dose of 180, irrespective of the timing and the loading as a dose of clopidogrel, unless contraindications to Ticagrelor exist. What about the switching between the antiplatelet drugs? The only switching algorithm recommended in patients presented with acute coronary syndrome is the switching from clopidogrel to Ticagrelor. This is the only switching algorithm recommended by outcome data. That's why this is because the drug may be related to the efficacy and safety of the drug. Why to reload? This is the issue of efficacy and safety. The drug may be more effective. The drug may be safe as the clopidogrel. The Plateau study, this is a major study about more than 18,000 patients. The study is conducted in patients with acute coronary syndrome, whether they are unstable, non-STEMI, or STEMI. These patients randomized to either per league at loading dose 180, then 90 mg BID plus aspirin, versus clopidogrel at loading 300 mg plus then 75 mg maintenance plus aspirin. And the patients followed for the efficacy and safety for about 6 to 12 months. Regarding the efficacy, the cardiovascular death, MI, and stroke. Regarding the safety, the plateau measure bleeding. About 46% of these patients, randomized to per league, already on clopidogrel therapy. In plateau, Ticagrelor per league achieve about 16% relative risk reduction regarding the cardiovascular death, MI, and stroke. So the drug is more effective in the reduction of the primary endpoint when compared to clopidogrel. Less incidence of cardiovascular death, MI, and stroke. Also, the incidence or the prevalence of the patients in need for target vessel revascularization was significantly lower in patients receiving ticagrelor versus those receiving clopidogrel. Target lesion revascularization means that patient perform PCI, doing a PCI, then in short term it needs to redo once more. يعني حط ستنت والستنت دي حصل فيها restenosis واحتاج انه يعمل PCI once more. The incidence of the patients needing revascularization was significantly lower in patients receiving ticagrelor versus those receiving clopidogrel. About the safety. The safety is measured by the incidence of major bleeding. The incidence of the major bleeding did not differ significantly between the two arms, between patients receiving ticagrelor versus those receiving clopidogrel. Again, the treat trial was conducted to compare the incidence of the major bleeding in patients receiving a thrombolytic therapy when randomized to either clopidogrel or ticagrelor, and the incidence of bleeding did not differ in these patients receiving a thrombolytic therapy. So the drug is as safe as clopidogrel when compared regarding the incidence of the bleeding. The response study is conducted to measure the responsiveness or during the use of clopidogrel. We meet what we say the clopidogrel resistance. The clopidogrel resistance means that the patient is not responding well to the antiplatelet effect of the drug. And unfortunately, we did not measure routinely the reaction units or B2Y12 reaction units. ده مش يوجوال تيست، احنا ما بنقيسش الريسبونس عاده للانتي بليتد ثيرابي مع الدراجز ما لهاش تيست محدد، انما في حاجه اسمها رياكشن يونتس بتنقاس. احنا بنشخص الكلوبيدوجلات ريزيستنس الا اكسيدنتالي، عيان عمل بي سي اي ودخل في اكيوت ستنس ثرومبوزس، عيان مانج ميديكالي بس بعد اكيوت ايفنت وحصل له recurrent cardiovascular event. Actually, Berlik overcome the non-responsiveness that the patient may meet when receiving clopidogrel. يعني احنا ما بنسمعش او ما سمعناش قبل كده على حاجه اسمها برليك ريزيستنس، انما we have well known what we call the clopidogrel resistance. The platelet inhibition used by Berlik is more uniform and consistent than that obtained by clopidogrel. How long adaptive duration? How long we should maintain dual antiplatelet therapy? For these patients, or this patient present with acute coronary syndrome, 3 months, 6 months, 12 months, or more than 12 months. Actually, the guidelines recommend maintaining dual antiplatelet therapy for 12 months. But in a sector patient or a major sector patient, we may recommend that the patient may receive antiplatelet therapy or dual antiplatelet therapy for prolonged duration. Why? This is because over the short term, Mr. Berlik achieved about 12% relative risk reduction regarding the cardiovascular death, MI, and stroke within 30 days. Over the long term, about 1 year, it achieved about 20% relative risk reduction versus clopidogrel. In patients, this is a recommendation of guidelines in patients with acute non-STEMI acute coronary syndrome treated with coronary stent during BCI, that with B2Y12 receptor inhibitor on top of aspirin is recommended for about 12 months unless there are contraindications such as excessive risk of bleeding. Prolonging antithrombotic treatment may be patients considered for prolonged antithrombotic treatment if they have higher risk or higher risk for recurrent cardiovascular event. Adding second antithrombotic agent to aspirin for extended long treatment, second prevention, may be considered in patients with moderately increased risk of ischemic events without increased risk of major or life-threatening bleeding. So the patients may be considered.
قدامك قد ايه كده ان شاء الله؟
لا مش لا دقيقتين بحق ربنا ان شاء الله.
دقيقتين فضلك.
So the patients may be considered for prolonged antithrombotic treatment as if he has high or moderate risk of recurrent cardiovascular events. Who are the patients considered at increased risk of thrombotic events? Patients considered at high thrombotic risk if they have complex coronary artery disease, in addition to one criteria: diabetic, history of MI, multivessel disease, or polyvascular disease, have ischemic heart disease and peripheral arterial disease. For example, if they have premature disease before the age of 45, or accelerated disease, new lesion developed within 2 years, from the time frame, or associated with concomitant inflammatory disease such as HIV or systemic lupus, or patients with CKD. Technical aspects considering the patients at high risk. These patients, perform more than 3 stents, or treating more than 3 lesions, at least 3 lesions, or total stent length more than 60 millimeter, or have history of complex vascularization such as left main BCI or bifurcation stenting, or CTO, coronary total occlusion BCI, or have history of stent thrombosis. Patients considered at moderate thrombotic risk if they have non-complex coronary disease, in addition to at least 1 criteria: diabetic, or have history of recurrent MI, or polyvascular disease, or have CKD, chronic kidney disease. دي بلاتو مثلا these recommendations عشان بس ما نطولش. The current indications based on results of the plateau and Pegasus. plateau دي احنا اتكلمنا عنها قبل كده. نتكلم عن Pegasus comparing 60 mg long-term benefit from antithrombotic treatment. Patients randomized to either Ticagrelor 60 mg BID or Ticagrelor 90 mg BID versus aspirin and versus placebo. Aspirin is in all arms, and the patients followed for at least and the patient followed من 12 ل 48 months. This is the design of Pegasus. These patients have aged more than 50 years with history of spontaneous MI within 1 to 3 years, with addition of at least high-risk feature such as age more than 65, diabetics, or or prior spontaneous MI, or multivessel disease, or chronic non-end stage renal disease. The patients they did not differ. The 3 arms, 90 or 60 or placebo, did not differ regarding the baseline characteristics. And it's clear that the 2 arms of upper leak, those of 60 mg BID or 90 mg BID, achieve significant relative risk reduction compared to placebo as average or median follow-up period about 36 months.
دكتور عمارة باشا.
خلاص. يعني السلايدز الباقية how to مثلا يعني عشان ما نطولش السلايدز الباقية regarding how to we summarize. يعني البرليك is first indication patients on STEMI. Patients should be loaded with drug immediately after presentation, regardless even if it is already on clopidogrel therapy. Berleek should be loaded at dose 180 mg, then 90 mg BID. The drug should be maintained for at least 1 year. Maybe prolonged treatment in patients was considered at high or moderate increased risk. And
thank you very much دكتور عمارة. الحقيقة good presentation وتوصل رسالة مهمة قوي. لأن في some sort of inertia برضو في وصف الدراج ده لأسباب صغيرة قد تكون هي فعلا. هو السؤال لحضرتك الأخراني علشان إيه نبقى هنا حضرتك شايف إن إحنا لازم في كل العيين النون ستيمي والACS لازم نديهم
في كل عيين النون ستيمي والعيين acute coronary should receive the drug unless there is contraindications. مثلا
زي ايه؟
عيان recent intracranial مثلا. عيان even ما فيش restriction واضحه في الدراج. يعني ما هوش restricted في العيانين حتى فوق 75 سنه. ما هوش restricted.
هي conditions اكتر يعني هي conditions اكتر. هو مديني ستريبتوكاينيز مثلا ولا لا؟
Even حتى treat trial proved ان لو العيان حتى receiving thrombolytic therapy can be loaded with the drug.
تمام. AF مثلا لو احنا عندنا stand